Welcome to Magnify Your Message. Inspiration magnified.
But this healthcare system, we're in the retail setting, we're paid just on the prescription. We're trying to get that changed. We always said we knew we'd kind of made it as pharmacists when we were getting paid to get people off of medication.
Today on the Magnify Your Message podcast, I am sitting down with America's pharmacist, Dr. Brad Tice. In today's healthcare landscape, where medication trial and error is way too common, Dr. Tice is revolutionizing how we approach pharmaceutical treatment. Dr. Tice is the former president of the American Pharmacists Association, and he created a company that is transforming the traditional wait and see approach to medication. Through cutting edge DNA testing, his mission is to eliminate the months or even years of suffering that patients endure while waiting for the right prescription. He was frustrated by watching countless patients struggle with ineffective medications and debilitating side effects during his years behind the pharmacy counter. And so that's why he pioneered this remarkable solution. And today, through a simple cheek swab, his innovative approach can help predict medication effectiveness, putting the care back into patient care. So if you ever use medication or know anybody who does, you're going to want to check out this episode. Have I got an interesting person for you to meet today? This is Brad Tice. Welcome, Brad.
Hello, Cheryl. Glad to be here.
Tell us, who are you and what do you provide in this world?
I'm Dr. Brad Tice, doctor of pharmacy. So, I guess maybe America's pharmacist. But what I mean by America's pharmacist isn't that I'm the only pharmacist or even the best pharmacist in America. I'm not claiming to be that. But what I am is really the pharmacist trying to put a face to pharmacy on for this country. Because, back in the day, we had the corner drugstore and we had the Norman Rockefeller painting that had the pharmacist and the drugstore counter and soda fountain. But we've lost that in so many ways, right? I mean, so many people don't even know the name of their pharmacist. And it's created this incredible problem in the country, which is adverse drug events. People don't realize this, but problems with using prescription drugs are estimated to be the third or fourth leading cause of death in the United States.
What?
Like,
That's staggering.
I mean, when you think about that, but the problem is they happen on different disease states, different medications, different drugs. And when that happens, then they don't get connected. But when you really look at all of them combined, it's a major problem. And so what we're trying to do, what I'm trying to do, is put a face to pharmacy and get the focus on using medications. First of all, getting on the right medications. Secondly, using those medications correctly. And third, achieving the desired results with medications, because our healthcare system has become so complicated that people really struggle with medication use.
Now, is it, gosh, when you say that it's that high on the causes of death, what is it ahead of? Like what's
More
one of the,
people die from prescription medication use than from diabetes each year. Think about that.
what?
And how much attention do we give to diabetes?
Right. It's something that's talked about a ton, but I've never even heard prescription drug, uh, misuse, if you will, or interaction as as a leading cause of death. That's staggering. So you talk about that, and then you also spoke about being on the right medications. Aren't they simple? I mean, I watch television now and again and see, hey, if you've got mild to severe, fill in the blanks, right? Plaque psoriasis or whatever, you should be using this thing. Isn't it as easy as self-diagnosing and walking
Well,
into a doctor's office?
well, think about that. Think about just watching television and how many commercials you see for prescription drugs, right? They changed the laws and regulations around advertising back in like 1994, and then that's when you started seeing all this direct-to-consumer advertising. What do you hear at the end of every one of those commercials?
Well,
The
first
entire
you
list of
hear the hideous side effects, which are
yes, the
sometimes so
hideous
much
side effects.
worse.
Like you were surprised anyone takes any medications when listening to that list of side effects, right?
Right, you could have occasional bedwetters who then it's like your head will explode and if you take this medication. It's only slightly possible and only on Tuesdays, however. And then I think it reads, ask your physician if this is right for you, or that's
Right.
maybe in the fine print. Is that what you're referring
The,
to?
the whole strategy is to get the get the get people going to their doctors and asking for specific medications, and it has worked. If you look at the use of prescription medications in the United States, there's not one year for the last at least 30 years where it's ever gone down. We just keep using more and more and more medications. We use medications to treat side effects of other medications, right? And if one medication doesn't work, then what ends up happening? We add another medication. We don't take a medication away. We add a medication. So why don't we stop taking the one that wasn't working instead of just adding one to try to keep fixing the problem? We just take more and more medications. And we really need to focus on being on the fewest medications that are going to work right and do as much as we can to get it right the first time instead of trial and error prescribing, which look, doctors are doing their best, but when this complicated health system that we have, they're pushed to do things faster and spend shorter amount of times with people. There's a real lack of follow-up in most healthcare settings. And then people start seeing specialists and they start seeing multiple prescribers. I was shocked back when Medicare Part D started, the drug component of Medicare Part D in 2006. There's a component of that called medication therapy management that some beneficiaries are eligible for, the members on Medicare. And for those people, we do this service where we called medication therapy management. We had to define what that service was. And part of it is a comprehensive medication review. But another part of it is just putting together a personal medication list, a single list that's up to date of a person's medications. And when we came up with that, I thought, really, that seems pretty simple. You would not believe how hard it is. It's like 20 years later, and that is one of the most, especially when you get into the elderly and older people, seeing specialists and on multiple medications, that is one of the most difficult things to keep up with, because what happens
Right.
is people go to doctor's offices and they end up seeing multiple people, and then they end up in the hospital, and the hospital changes their medications, and they come out of the hospital and they don't get changed back from the one, and it's just really confusing. And so that's part of why we have all these problems.
As you explain how that occurs, and there's so many people treating an individual, particularly if they're in a critical situation where they're hospitalized,
Right.
starts to make sense that combined medication and the improper medication could actually be a cause of death. It makes good sense. Okay, I have to address the elephant in the room here. You're a pharmacist who's advocating for people being on the fewest amount of prescription medications possible. That is so antithetical. It would seem as though you would be advocating for the reverse. Hey, try this one. The only side effect is this, but you could deal with that with another drug. But you're saying something different altogether. Now, I have to say there's something I know that you do that I promised everybody this fascinating conversation, and there's something in the way you work that is so fascinating, and I want you to share it with everyone. How in the heck do you get people on the right prescription right out of the gate?
Well, sure. So the first thing that we do is we test a person's DNA to identify what medications they are going to respond to the best. Because we now know that people metabolize drugs at different rates, and we can knowing how the medications are metabolized and then what their DNA is, then we understand that some people are what we call poor metabolizers or slow metabolizers. Some people are intermediate, normal, or ultra rapid metabolizers, right? So you got two spectrums on the far ends. You have the slow and the really fast metabolizers of medications. But what happens is when the drug companies, especially in the past, got drugs approved, they came out with dosing guidelines based upon the clinical trials that they did. And when they dose and create one standard set, it doesn't account for the fact that there's these poor metabolizers and ultra rapid metabolizers, just to keep it simple, right? And so if you, for a drug that comes into your body that you are just going to metabolize and it's going to be active and you're just going to process that drug, think about it. If you are a poor metabolizer or a slow metabolizer, then it's going to linger around in your body a lot longer. You're likely to have more side effects. If it's an ultra rapid metabolizer, in this case, it doesn't stay in your body as long. And so it goes really fast and you don't have as much of a therapeutic effect from that drug as you would normally experience. So we oftentimes just use the example of caffeine. It's a mild drug, and we all think about caffeine. Some people say they can't have caffeine after 2 or 3 in the afternoon, and
Some
some
people drink
people
it at night.
at night. Well, it's because they're ultra rapid metabolizer and versus the poor metabolizer. That's just one example
Yep.
to help people.
Are there other factors other than the rate at which one metabolizes
A lot of
that
it's
you
around
discover in
metabolizing.
DNA?
There are transporters, like how a drug gets transported across the cells and
Mm.
some different things like that that are turned on and on. There's drugs that induce enzymes and drugs that inhibit enzymes that you have to be aware of and consider. And so, yeah, going back to what you were saying about a pharmacist wanting just to prescribe more medications, it's like, well, yeah, that's why, look, we don't go to school and be trained for 5 or 6 or 7 years to just put pills from large bottles to small bottles, right? There's so much more to it than that. But this healthcare system, we're in the retail setting, we're paid just on the prescription. We're trying to get that changed. We
Mm.
always said we knew we'd kind of made it as pharmacists when we were getting paid to get people off of medications,
Wow. Yes.
right?
That's fascinating. So one of the case studies, so to speak, spoken about that's so mission critical to get right. You and I were having a conversation and you'd spoken, we were talking about the mental health crisis
Yeah.
that people are facing now. And it's become particularly prevalent or at least discussed since the pandemic. And
Mhm.
you talked about the normal trajectory for someone taking some kind of medication for their mental health, depression, antidepressants,
Yeah.
anxiety medications,
Yeah.
and the normal time frame it takes to dial those in versus what could happen if their DNA is actually tested. Say something about that. It's
Yeah.
mind-boggling.
So when you go to a doctor or psychiatrist to get a treat depression or a mental health disorder or illness, then they choose a drug that they're used to using, and there's no lab test. You're not testing a person's blood to know is there cholesterol, is there blood sugar going up or down, and so it's a survey instrument, and it's the assessment of
The
the doctor.
drug?
No. What the doctor uses to assess if you
Oh,
have
I see what
anxiety,
you
if you have
meant. I thought
depression.
you meant they were, like, by testing the individual, so to
Oh,
speak. I get it.
Yeah.
Okay,
Okay.
keep
And
going.
so they do the survey instrument, they determine if you have, and they use their professional training, right? And then they put you on a medication. And then it takes at least, 30 to 45 days in general to get to steady state. So you're taking the drug for 30 to 45 days. Well, then what happens? You go back and you're reassessed. And the doctor says, okay, it sounds like the drugs might not be working. Let's increase the dose. Or maybe you have side effects and have to change a drug, or maybe they decide to, they usually will titrate you up a few times before they decide to switch drugs, right? Or add a drug. What happens oftentimes is this is where we get multiple drugs. And so then we had one very large company that does on-site health clinics for large corporations. They said it takes them an average of 8 physician visits to get a person on the right medication regimen. So 8 physician visits. So when you think of 8 physician visits, think about how long that takes. It's probably 8 to 10 months. That is 8 to 10 months, not just of additional healthcare costs and additional inconvenience. It's 8 to 10 months of suffering. And so some of the best evidence is in these drug categories for your genetics. And if we can say, don't start or don't even attempt these 1 or 2 drugs, and we can start you on the right drug faster, then let's do that. And let's avoid the trial and error and the practicing of medicine on people and try to get it right faster. And that's the average. We've had people that we've seen that have said it's been 2 to 3 years that they've been
Yes.
dealing with this, right?
When you said 8 doctor visits, I'm like, I love my physician, but 8 visits in a year, there's no way. It would
Yeah,
take,
yeah.
I tried to call for some innocuous thing to get on the calendar for, and
Oh,
they were
yeah.
like, how's, let's see, it was like 7 months from now.
Yeah. And
Six,
so,
6.5 months to be fair,
and
but
just think of
still.
the, to that point, the shortage of physicians and specialists that there is now. If we could get people on the right drugs faster, free up all that time, people could get treated more timely at the same time. And so there's so much we can do better.
Imagine if you are dealing with a mental health crisis
Yeah,
and it takes you 8 visits with a physician. I mean, I could imagine that would couple years, just
right.
conservatively, getting in quarterly to your physician. You don't need help someday. You need help right this instant.
Yes.
It's staggering.
We had one person that was going to the emergency room. She's part of the VA. She's going to the emergency room for 2 years. She finally got a referral outside of the VA, and she had a test done. And she called the emergency room physician who had a relationship with her by this time because she'd seen her so many times. And that patient told the doctor, hey, I'm not crazy. We've got this test done. I'm on the right meds now and I feel great. But it took 2 years of emergency room visits and costs and the person thinking that she was quote unquote crazy and she was
God.
suffering. And so there's just so much
Mm.
better that we can do.
The travesty for a veteran. I mean, for anyone, let's face
Yeah.
it. There's a mental health crisis with children age 8. I read this
Yeah.
study with suicidal ideation at this point, but a veteran who's quite possibly dealing with PTSD, to be dealing with this insanity of for 2 years of just trying to get on the right medication. That's why when I heard what you did, I thought, wow, this is why we need
Yeah.
to start calling you and relating to you as, in fact, America's pharmacist. I don't know anybody else who out there who's testing DNA before just giving more medication. And like we'd already touched upon, suggesting less medication rather than more medication. It is like that right there. When talk about the Norman
Oh, yeah.
Rockwell paintings, that's like that sounds like the pharmacist from days of yore.
Right.
I just it's fantastic. It's so
Well, it needs to be fantastic. It needs to get out there a lot more. But one of the challenges with getting it done more is, well, there's several challenges, but the getting doctors and even pharmacists to recognize this, because I mean, there's studies out there that it takes 17 years to get new treatment guidelines into healthcare because the healthcare system is so big and enormous. So, and like I started doing this more than 10 years ago because in 2010, the Food and Drug Administration put on the prescribing information that the doctors and pharmacists read a black box warning. A black box warning on a drug called Plavix. Now it's generic as clopidogrel. It's for secondary stroke prevention and acute coronary syndrome, which is like a heart attack. And that drug is a little bit different than the one I described earlier. This is called a prodrug, and a prodrug is one, I just use my example of my hand. It's a prodrug comes into your body like this, and your body has to do something to make it active. So it's inactive when it comes into your body, but your body metabolizes it a little bit and turns it into an active form, okay? So this is the active form. 12 to 42% of people using that medication can't do this. And so it's like not doing any good in their body to treat a secondary stroke or acute coronary syndrome, right? It was the third highest retailing drug in the world before it went generic. That's how often this drug is used. And to think that 12 to 42% of people can't metabolize it to its active form, and it's the black box warning recommends genetic testing, and it wasn't being done. Now
oh,
that's partly because at the time it was $3,500 a test, so it was expensive, right? And so, but now it's come down into just the hundreds of dollars to do the test. And so now, and when we do the test, we don't just test for one specific drug. We test all drugs at one time. It's just more efficient to do it that way. So then you have the information to use into the future whenever you're considering a new medication. Now,
oh wow.
the
So
other
that's brilliant. Excuse me, I interrupted you.
but
I'm
it's
still a little
also
lost on the 42% of
oh
people cannot do anything with the medication.
and so the
Yeah.
42%, that's really broken down by ethnicity a lot, because the Pacific Islanders, the Asian population, is kind of the 42%. Well, what happens when the clinical trials are done by the drug companies? They mostly use the majority population and Caucasian in the United States, white males a lot of times. And so that minorities are underrepresented. And so then they don't get, if that's what's causing some of the changes, then they don't get represented in the dosing guidelines. So there was actually a lawsuit in Hawaii where the Pacific Islanders sued the drug company and won a like $800 million plus lawsuit, I think in the 2020-ish, give or take a year. And I think it's being contested, of course. But that was just one example of that coming to that. But that took 10 years to get there, right? Codeine, everybody knows codeine, right? Codeine for pain. It's not used in adolescents anymore. It's not recommended to use in less than 18 years old. Why? Because when you look at the label, it's because of it's an enzyme called CYP2D6 pathway, and it was causing death in children because they were not metabolizing it fast enough, and it was lingering in their body and causing side effects. So
Good God.
yeah,
It's such a
so
landmine out there.
and people don't even realize it. And yet now there are over 100 drugs on the Food and Drug Administration website that they have published where there's significant safety or clinical implications. And they even say this is just the start. There's an organization called CPIC, the Clinical Pharmacogenetic Implementation Consortium. I know that's a big word, CPIC. There's over 400 healthcare professionals, doctors, pharmacists, PhDs that have reviewed the literature that's out there and created prescribing guidelines. And these are not being, look, to just any listener, raise your hand. Have you had your DNA tested? I bet nobody's going to raise their hand for this. And if they haven't, then there's no way the doctor's got the information to use, and it's not being used in the selection of their medications when they need them. And it could be making a huge impact.
Wow. I mean, I can't imagine what there is to keep up on in being a pharmacist. So
Well,
this is
pharmacist and
not
doctor, because at least as a pharmacist, I only got to worry about the medications. The doctor's got to worry about not just the medications, but
I
all the
can't
diagnoses. And
and
that's why it takes 17 years, because they just can't keep
wow.
up.
And as litigious as this world is,
Well, I'm glad you brought that up,
it's
because that's
it's
why,
frightening, but
yeah, when you get multiple doctors, they don't want to touch a prescription medication that another doctor prescribed, because then they're responsible for it and they don't know all. So
mm,
then that's where you get a lot of these challenges. And then last, not well, and then one more thing is, I talked about storing the DNA and being able to use it in the future. Well, the healthcare system infrastructure is not set up to do that. They're used to thinking of a lab test as that you get a result and you make a decision and you use it, but it's going to change. Like, okay, we're going to test your cholesterol today, and we're going to make a decision about your cholesterol medication if you need one or not, and then you're going to come back in 3 to 6 months and test it again, and because your blood levels have changed. Well, your DNA doesn't change for the most part. It's a little more complicated than that, but what we need to be doing is storing that result and then being able to use it for future medication selection and not having to pay for additional tests. As long as we've tested the gene, we can update the information, but we if the only time we'd have to retest is if there's new genes that have become that we didn't test for originally, and that can happen. But for the most part, there's so much information that we could use that we just need to store it. But there's drug health insurance companies, they don't have a way to do it. Most electronic health records don't have a way to store that kind of information. We're working on creating that as well, and then being able to enable people to have that information in the future for them and their doctors.
would you share it with your physician then, or the
Absolutely. Well,
pharmacist, or both?
hopefully by the end of the year, we're going to have an app that people can have on their phone, and then they have it with them. And anytime they're going to try a new medication, they can check to see if there would be an interaction with their DNA, so to speak, just like we do drug-drug interactions. We could do drug gene tests, and then they
Wow.
can take that to their doctor. And when they're considering a new medication, well, let's check it before prescribing it. That's kind of our goal by the end of the
That
year.
makes such good sense. I mean, it I a few years back, my mother was in the hospital, and I was amazed. I don't if for any of you who spent a lot of time in hospital, medical care facilities like that, or you're a medical provider yourself. I was a neophyte. I had not spent that much time in the hospital. My mother got some hospital-borne secondary illness and
Yeah.
ended up being hospitalized for months. And I had to advocate for her
Oh,
so
yeah.
strongly. I was shocked to learn that.
Yeah.
If I didn't, and I had to put signs up in the room, like if I went out for a moment, do this, don't do this. I
Right.
was shocked, and she has a great healthcare system with good insurance.
Mhm.
And it was shocking to see how I thought, what would she have done, being soft spoken, uh, if I weren't there to advocate for her? Who would have
Yeah.
advocated for
And
her?
and
And
how many people have someone like you who could be there or was there? So there's so
right.
many people that do not have
And
that.
I think as you're speaking, I'm like, wow, we really must advocate for ourselves,
Oh, yes.
and not just to I don't know if demanding this kind of thing from our own health care insurance would be helpful, or getting it and then sharing it with our physicians, but it's when you talk about the number of deaths
Yeah.
caused by this,
Mhm.
there's only advocating for ourselves. There's
Yeah.
no one out there but
And
us.
and and the challenge is this, I mean, the first time you're in it, it's the first time you're in it. You don't know what questions to ask. You don't know what to look out for. It can be a real challenge.
Mm.
for
Wow.
sure. Mm.
How can people learn more about you and the work that you do, as well as how can we get DNA testing for ourselves?
And you can go to our website. We tried to make it simple to remember. Exact Meds, getting you on exactly the right medications that work for you. So go to exactmeds.com and you can check it out there. We have a little bit more robust of a website. RX Genomics is the name of the company, rxgenomix.com. But you can go to exactmeds.com, purchase the test, you know, and we include a pharmacist consultation. It's not just a uh, it's a cheek swab. It's easy to do. Like, we send you the kit at home, you do it, and then you get the results, and you go over the results with the pharmacist, because these Food and Drug Administration says this is not ready for direct to consumer. This is like, you can't just go pick it up at a store and get those results back, because they are complicated and there's lots of different implications. So we really want to provide that consult to make sure that the information is used correctly and people don't get scared and just all of a sudden stop taking a medication when they
Right.
shouldn't. And so it's
Smart.
a little more complicated than that. But yeah, exactmeds.com, and can purchase it, and the service, and the more people need to know about it. And we even then work with your doctors if that changes need to be made, because sometimes you don't, you may not be comfortable, or they may not be familiar with the literature and the information that's out there. I've gone to so many doctors' offices in the last year and talked to them about this, and so many just are not even aware that the extent, they're usually aware that it exists a little bit, but they aren't aware of all the implications. Most of them are not aware of CPIC. And just do a search. If you want to just look at what's on the Food and Drug Administration website, it's a table of, well, it's a big word, pharmacogenetic biomarkers. But if you just type in a search for Food and Drug Administration and drug genetics, it'll probably come up that way.
I'll get the links from you and
Oh,
include
sure.
those in the liner notes of the
Well,
episode.
then I'll provide the CPIC links too, to see there are actual prescribing guidelines. There's over 26 of them there that um, that are there just for prescribers to just understand, and just it provides the direct prescribing pathway of what they need to be looking at. There's one drug, for example, it's not alone, but depending on your genetics, you might need half of the regular starting dose or 2.5 times the starting dose. And that's for a very common drug for heart failure or blood pressure. And so it's pain medications, and it applies to so many different, I mentioned codeine, but we talk about people not getting their pain treated appropriately, and there's so many medications that have literal 10 to 15% or 30% of treatment failures and people responding, whether that's something as common as ibuprofen to some of the more stronger pain medications. So it applies to so many categories of medications that people just need to hear about this more and understand it more. So thank you for giving us this opportunity to get more out there.
Absolutely. Thanks for sharing your time today. It's really eye-opening. I hope you were as enlivened by today's episode with Dr. Brad Tice as I was. It's pretty remarkable stuff, right? Join me next week for another interview with another person who is making a big difference in the world through their work. I'll see you then. If you enjoyed this, please like, subscribe, and share this episode with everyone that you feel it would benefit. Thank you in advance. And when you're ready to share your story and your work with the world, I can help. Visit CherylHunter.com to learn how. I am Cheryl Hunter, and until next time, know that your message has the power to change the world.